Welcome to our wonderful country. As you can hear, we have a very pretty country, but we do have some problems. So I decided to change the topic of the slide, but it's not up there. There, as Sanak on drugs. You know, and what we're talking about is, it reminds me of a little story, well, now 30 years ago, when my son, who's now a big man, was about this high, and his grandfather was teaching him to play golf. And I don't know how many golfers are here. So, I mean, that's where you learn to swear and learn, you know, all the bad habits come from there. But this child was diligently practicing every afternoon. And eventually, my father decided, okay, he will take him out onto the golf course with him. And this child didn't sleep the previous night. He had everything. He had the right outfit. All of it was there. And they teed off, and the child was just hooking every ball. I mean, then it goes there, then it goes there. And by, I think, the 6th or the 7th hole, he just put his club on the ground, and he said, "I'm just embarrassing you, I'm going home." My father said, "No, stop right there, pick up your club, come back to me, and look back to where you teed off." And he turned him around, he looked at the tee, and he says, "Just look at how far you are from where you teed off. So this might not be exactly the right direction that you wanted to go into, but you've come a hell of a way from that tee off." And I think sometimes we forget that. Sometimes we just want everything overnight, and we want it done. So if you work at the South African National AIDS Council, you get quite used to just feeling overwhelmed and think, this is never going to happen for us. You know what? It will. So we have made some progress at least. So this is, and Dr. Ganaka in the opening speech referred to the National Strategic Plan. And what I thought was, I'm not going to go into the National Strategic Plan. Those of you who are South African probably know the plan by heart. We have 8 goals. We have 5 critical enablers. And the first goal is prevention, 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 prevention. We still have 270,000 new infections a year in South Africa. You know what? Just as we thought in South Africa in 1994, this is it. We're going for it. We were banged down with the worst HIV epidemic in the world. And for us to have come this far, we have the largest treatment program in the world. And yes, we still have 270,000 new infections. 100,000 of those are from adolescent girls and young women. So what I'm trying to get across is, although we've been focusing on treatment, getting everybody on treatment, we haven't closed the tap. So on the prevention side, we still have lots of work to do. But we're learning all the time, and we're getting there. So I'm going to explain to you. So I thought instead of going into the NSP, I'm going to explain to you, how do we apply this? How do we work around these things, the problems specific to South Africa, coping with all of the social problems we have, coping with HIV, coping with TB, which is the main killer in South Africa, and also with STIs, and just how we get there. So bear with me, you will get out of here before 7. So if we look at this line, then that is the line of any chronic disease, if nothing is done. So it starts with, can I go there, or am I breaking rules like usual? So if you look at a public health model, then we talk about primary prevention, we talk about secondary prevention, and we talk about tertiary prevention. The thing is, if we can, so this is in terms of HIV, if we can get people here, remember, although we have this huge HIV prevalence, 80% of our population are still HIV negative. So we cannot forget about them. So we have to keep them negative. That's our primary prevention. So the bulk of our work and the bulk of the focus of the new NSP is going on prevention. Right here, when people turn positive, we have to get them early. So we have this huge testing campaign. 2 years ago, we tested about 15 million people in 18 months, and we're going to relaunch that campaign. We're going forward with trying to test, getting everybody to know their status every single year. If we get to tertiary prevention, this is where treatment comes in. This is if you do nothing, then people progress, and this is when the CD4 drops to about 250. Then we go into this zone where people are compromised, they are ill. And this is the zone that we want to prevent at all costs. South Africa is severely resource constrained. Very few health sectors or health health departments in the world would have been able to cope with what we are coping with here. But the problem is, this is the expensive part. So we have to keep people out of this part, and that's why this is so important. If we can keep people negative, we can delegate the care of those people back to the community, saving those resources. If we can find people early, we can interdict illness. And I'm not only talking HIV, I'm talking comorbidities, I'm talking TB, I'm talking STIs. If we can get it early, we can manage it here and help or get the communities to accept responsibility or to help cope with the disease. We don't need to go here where we need hospitals, where we need tertiary care. And the same here. If once we can get, so the whole objective is to straighten this line. So if we can just get people to continue along this line without dipping in there, we can help ourselves to develop a community approach. I do want to caution about one thing, though. So at SANAC, I'll answer your first question. So SANAC reports to the Deputy President of South Africa. So this NSP is important. This NSP is the framework onto which all of the other plans hook onto. And what we have done right, so for the first time in this NSP, there's a whole chapter just on key populations. And what we got into, as far as this conference is concerned, not only people who inject drugs made it into the NSP, but people who use drugs. So all people who use drugs made it into the NSP. We also got OST in, we got NSP in. So for the first time, there's a huge progress as far as that's concerned. The answer to the second question, we have a full chapter on human rights, but also on social and structural drivers in South Africa, because in South Africa, you cannot program without looking at the very specific social and structural drivers that communities are dealing with. And what we do and tend to do is, it's so easy. We've almost, because it's been such a struggle, we've almost jargonized a lot of the sentences we use in our approach. You know, it's so easy to say community approach. That's not that easy, because some of these communities are really struggling with huge burdens already. And we must be very careful to just, throw everything back at the community and make it a community approach without supporting them, without developing them, without helping them to cope with these additional problems that we are deferring back to them. So if we look at primary prevention, we look at health education, we look at the latest buzzwords, social behavior, communicate. What do now? Okay, this is getting professional. Can I sing? I can't sing. Social behavior change communication, and here again, unless we get an evidence-based way of delivering social behavior change communication, we're going to not make it. It's so easy to put SBCC as a line in a thing, and then we're not clever enough to deliver SBCC with the effects that we are looking after. So what David referred to and I'm going to show you how we're going to use this model and apply it to how we deliver drug services. But whereas with what you referred to in the drug model is that the lack of a biomedical model. In HIV and AIDS across the world, what we've really done is to use only a biomedical model. So we've really got, 90-90-90 is as biomedical as it gets. So we must be very careful that in our approach, although our targets are 90-90-90, 90% tested, 90% of those on treatment, and 90% of those virally suppressed, we must make sure that we do not leave all of these other things behind, because this is where the crux is, and we will not get to 90-90-90 unless we can look at these social and structural drivers, because I think that's the one thing we realize in South Africa. We cannot treat our way out of this epidemic. So here we're looking at health education, we're looking at condoms and lubricants, tons and tons and tons of condoms and lubricants. It must be available like tissues, it must be everywhere. And then HIV, TB, and STI screening. Secondary prevention, we're looking at early detection, finding what's out there, interdict, stop it early. Safer behavior, reducing stigma and discrimination. That's huge with all of our key populations and also with people living with HIV. There's a lot of self-stigma because some of the healthcare workers are stigmatizing. They are really a barrier to healthcare services a lot of times. And that's why with the very sensitive key populations like sex workers and people who inject, the hugely stigmatized populations, there are even greater barriers. And so in South Africa, what has happened with some of these services, or most of these services, are really pockets of excellence in parallel with government services that have developed. And that's how we've been delivering most of these services. And then early treatment, as I said, and PEP. Here what we need is not the community to take the lead, but the community to support, help these people, support their family members while they're in hospital. And then also ART rescue, make sure we get the people back so that we can retain them in services, but also to study this epidemic. And I mean, I think it was quite clear from what Andrew said, we are lacking far behind on adequate research and information on the epidemic. So if we take the same model, and we apply it to, well, I put the people who inject drugs, but what I wanted to show was, in this model, people who inject drugs is probably falling in this tertiary part, and the whole continuum is, so it's within, and that's how we see people who inject, is within a continuum of care, rather than as a specific group that should be looked after in a pocket. Rather do it as a continuum of care. Make sure that we have clever health education, behavior change stuff, leisure activities available for the kids. Make sure we give alternative gangs to the kids. Make it interesting. Do the sports and who's doing the dance and all of these things. Get some other clubs there for the kids to belong to. Make sure we screen for hepatitis B and C. Immunize for that. Making sure that we get earlier care-seeking behavior, get rid of the stigma. That's the only way in which we are going to get people to come to the clinics. Unless we remove the stigma, it's not going to happen. And that's why these parallel services have removed that barrier. They're welcoming to the populations. And then also part of the drug master plan is the regulation of controlled substances. Make sure that in these clinics, and lots of these clinics are in rural areas, that the drugs that should be available, the pain control, all of these things, are actually available. And then David also referred to that. Make sure that in this phase where we really need good quality medical intervention, that those services are available, but make sure it's available in the community so that those communities have the resources available to be able to respond. We can't just tell parents to take care of their family members who have a problem without empowering them to be able to respond with it. And I think that's another thing that I want to caution. I'm not sure how many of you have children, but my children certainly didn't come with a textbook. So we must be very careful that, in talking around these things, that we don't name and blame and shame, even if it's not intentional. But, if you talk to a community, don't talk about, this could be a parenting problem, because then you lose them again. So it's so important. The language, and I think lots of people have been saying that, the language is so important. That language must be sensitive. Otherwise, we're not going to get it right. And then, as I said, these things are now in the NSP, so we can look forward to rolling that out. One of the big things in South Africa, because we're so resource constrained, is we developed the new National Strategic Plan, but in the back of our heads, we also realize that there's no additional funding available. So it's going to take lots of very clever planning of how we do this within the existing budgets. So one of the chapters in the NSP is specifically on resource mobilization, raising funding for these problems and making sure we do it. The best way to be a star, the best way to attract good funding is by being very clever. So you must either be very sexy or very clever. I'm not sure we can do the sexy thing, and we're getting a bit on in years, but we can certainly try to come up with very clever new interventions, new ways of doing the same thing. It doesn't have to be the same old things. And I think a lot of speakers have been talking to that as well. We keep on doing the same things thinking it's going to make a difference. But we certainly, think I said that before. We do need to understand what we're dealing with in a way, and for that, it's not only counting outputs. We have to understand what we're trying to get to, what we're trying to achieve. Remember my golfing analogy. We must know where we're going, otherwise it doesn't matter where we go. It doesn't help to just do activities and we don't know whether we're getting anywhere. And then also to keep track of people. So I don't know if you think that this model can be transferred, but we certainly think we do. So the call to action, what do we need to do? We need, and this is where, so that's the third answer, this answer to your third question, Yanni, is advocacy strategy. At SANAC, we have 27 sectors. As Andrew said, there's no sector for injecting drug users, but we have a very strong and very active sex work sector. And at every meeting, they are there, and they're screaming, and they're fighting, and they want decrim, and they're very active. And we don't see that with the injecting drug use, or for people who use drugs, for instance. So I think we need to make sure that we lobby, that we get word out there, that it's, you know, that everybody is aware of what we want, because if they don't know, they might not change it. Independent governance, David referred to that. I think it's important for the CDA to be able, like SANAC, that is a statutory council, we can take our own decisions. You know, the whole idea is to be independent to take those decisions. And I think it's very, very important that the CDA must have that freedom to move. Otherwise, you can't be independent. You can't take decisions without being influenced. You captured, David. We need leadership and we need coordination. It's very, very tricky to coordinate 17 different departments. You know, you have to speak at the right level with the right decision maker on the right day, because otherwise you can still miss it. So we need resilient communities and individuals, and as I said, I'm pleading for respect and dignity also for the communities. We are accountable to these communities. We are accountable to the Deputy President. So that's almost everybody in South Africa except the President. So we're really accountable. We need funding, and we need surveillance, and we need research activities. We need to understand what we do. Oh, no, I wanted to do. So can you see in the background? So this is what I mean with clever design. So this is a urinal at Schiphol Airport in Amsterdam. So there are lots of men here. So as you know, men are always in a contest. They're always, you know, measuring. So at Schiphol Airport, what they did, you know, if you walk past lots of men's toilets, then, you know, it really is not very hygienic, or, you know, from where we're sitting, it doesn't smell too good. But so what they did is they painted a fly in those urinals. And what do men do? They're all aiming at the fly now. And they've reduced missing the bowl with 80%. And that's how we should start thinking. We should start thinking clever. Those men who go there and aim at that fly don't feel manipulated. They don't feel as if you're telling them to stop taking drugs. They're going for a fly. So we must find the flies, and we must make sure that that's how we influence to not only address people who use drugs, but also HIV, TB, and STIs. And then the last slide is just of our poster boy. Is he still here? Where's Nelson? Is he here? So that's just goal 3 of the National Strategic Plan, and we have Nelson on the front cover of that. Thank you very much.